So most of the time when we practice breast imaging, it's very cerebral, very calm, you're talking to the patient. MRI is the one area where I think that's actually the most dangerous aspect of our practice, is going into MRI. And it's because of flying objects and safety issues. Critically important to be knowledgeable about MR safety. We now have an MR safety officer. We have a dedicated person who manages the MR safety program, and I'll tell you, I have to re-qualify every year for my access to the MRI suite. And for us, the technologist is the leader. So I am the radiologist, but in terms of safety, I don't give the last call. The MR tech actually can prevent me or anyone else from going into the magnet room if there is a safety concern. So frequently asked questions: is this patient's foreign body, device, or implant safe to bring into the MRI? Can my pregnant patient undergo breast MR screening? Can I breastfeed after an MRI? That's if you've delivered and now you're lactating. Is it safe for me to receive the contrast, the gadolinium? And that gets into brain deposition, nephrogenic systemic fibrosis, and lastly, very commonly, hives after my last scan of whatever. And is it safe for me to get the dye? So contrast reactions, of course, are another aspect of workflow, in addition to things that are okay or not okay to bring into the magnet. So the question one is the million-dollar question, the one that is, I think, most critically important, because this is where you could hurt somebody or even kill someone. So is it safe? Remember, the magnet is always on. I remember when the news story came out, believe it or not, I had a friend who was a physics major, and he thought that the MR turned off. He's like, why did they leave it on? And I was like, well, the magnet is always on. So I did some education. So even in this day and age, people don't recognize that you don't turn off a magnet. So no metal in the magnet is the dogma. There's posters. Every MRI scanner has these posted. They have all sorts of warnings. The problem is it's become noise. People ignore them. They see it all the time and then they ignore. But just so you know, you should at minimum have some kind of awareness. And for us, we've decided we need to change the culture around MRI, that it is a place to be feared when you go in, and don't just assume that because you work there every day, everything is all good. So the old terminology, MR safe, means no risk to the patient or the staff or anybody. And it can affect the quality of diagnostic information. MR compatible meant that it was safe and no significant effect on diagnostic quality, device operation not affected by MR system. I find this horribly confusing, and so did the rest of the world. So that's why they changed it. MR safe versus MR compatible were pretty much used interchangeably. So current terminology is to help reduce some of this confusion. Just like BI-RADS reduces our confusion of what's abnormal, what should be biopsied, the MR terminology has shifted to try and make things very, very clear, along with the symbols. MR safe means it truly is safe in any kind of MRI environment. Pretty much means plastic things, like a plastic petri dish, okay? Non-conducting, non-metallic. MR conditional, this is the tricky one. This is where you meet conditions that are safe to operate or that are not going to do harm to patient or to device. So this will depend on field strength, on gradients, and the specifics of what exactly are you trying to image and achieve. It addresses thermal injury, nerve stimulation, safe functioning of the item, and certainly no damage to patient, right? They come in, they come out, they're intact. MR unsafe, that's pretty clear. This is something that's going to be dangerous. So scissors, right? Anything a surgeon brings in or an anesthesiologist brings in. So they stay out of the magnet until they're cleared. So here are the symbols. Green, MR safe. Yellow triangle, MR conditional. And then the universal no sign, big red slash through it, MR unsafe. So these are universal all over the world. Everyone has adopted these symbols. And they're on everything, or should be. So the MR conditional is the one that we have to make some kind of judgment call. Okay? So the question to ask about safety if there is metal that needs to go into the scan room, or should it go? So first off, you shouldn't bring it in if you can avoid it. But things like aluminum, people think, oh, aluminum is non-ferromagnetic and doesn't get attracted by a magnet. That is true in a perfect world. But I remember a very compelling video from one of the MR manufacturers where they were decommissioning a magnet, and they took a soda can and it went flying into the magnet. They had a barrier set up, but it just smashed in there. And that's because of the impurities in the can. And this was a 1.5T. Imagine what it would do in a 3T, okay? So don't assume that aluminum is safe to bring in. So the old days, I remember I had an MSK attending say, oh, if you're worried about phase artifact, no worries, just wrap the knee that's not of interest in aluminum foil, and then you won't see it, right? It'll be black. But don't do that, because the magnets are much stronger now, and impurities in, the Reynolds wrap can go flying into the magnet. All right. For biopsies, for breast biopsies, we bring in regulatory, MR safe, MR conditional materials. The manufacturers charge us a lot of money for these things because it has been proven, it's tested in the specific MR environments. And even then, I'm wary. I don't bring it really close. I keep it as far away as possible within reason. Luckily for MR biopsy, we bring the patient out to us, okay? So if the patient has metal, hip replacement, something that's inherent, you have to think about deflection. What if it moves? What if it heats up? What if it stops functioning or changes function? Okay, so joint prosthesis usually is fine. Of course, sometimes you might have a patient complaining of discomfort or heating. So the patient's always right. If they're uncomfortable, you stop, you bring them out. Metal in the eye, obviously, big no-no. So we get CT scans for foreign body rule out. And the neuro team has been really great about reading these in real time, right away. CT scanner, get the patient on right before their MR, clear them before you put them on the magnet. So during an MR biopsy, that vacuum biopsy system console, that is MR unsafe. That stays outside of the scan room. Never bring it into the room. MR conditional objects may make its way onto your biopsy tray. I remember when someone in purchasing changed the type of scalpel we were using, and we went from a scalpel that laid nicely flat, didn't move on the tray, to one that was inching towards the magnet. And so now we actually have the support person, the second person, as I call it, our nurse or hospital assistant. They will walk in with the scalpel when you need it. You hand it back to them. They hold on to it. When you don't need it anymore, they walk right back out with it and dump it in a sharps. Because I have not found a good scalpel that can cut that is also okay for MRI. Unfortunately, they gave us one that was ceramic, but it wasn't actually able to make a skin nick, so we got rid of that. Spinal needles, by the way, also will move. So most of the spinal needles, I have not been able to find one that won't move in a 3T environment. So it may have been okay at 1.5. At 3T, you see them scooching along the table, so I don't let those in, those don't come in on the tray. So we just use this protocol to hand to a staff person, okay? So some of the historical bad events, and this is how we learned about MR safety. Unfortunately, people died, aneurysm clip that dislodged, iron filing resulted in vision loss. These are from 85, 1992. But these days, we actually find skin burns still happen. And that's because patient might cross their arms or cross their legs, or they touch skin-to-skin contact, looped wires, cables. So these are just things to watch out for. It's part of that safety training for all the MRI techs and the helpers. Skin-to-skin, cable-to-skin, anything that's going to close the circuit can cause a burn, all right? That is a very common MR safety hazard, and we haven't been able to prevent it completely, unfortunately, even in my own practice. So here's an example. This was published in 96, actually, so we've known about this for a long time. The patient had liposarc resection, was getting routine MR, and unfortunately the medial aspects of the calves were touching, and that created that burn. So skin burns, caused by a closed conducting loop due to skin-to-skin contact. And this happens sometimes in a delayed fashion. So you may not notice it right away, but later they get the burn. Here's another one. This is a direct contact burn. It looks horrible. It's cable to skin contact, okay? So the techs hopefully will be using good technique when they position patients. That's why there is never direct skin contact to anything. And that's why in MR, for the coils, you don't want to touch the skin because of near field artifact, but also you don't want the direct coil elements touching the skin because you don't want to cause a skin burn. So give them some space. In MR biopsy, we are touching the breast with a plastic grid. So there we are compressing, but we're actually not allowing coil to skin contact. There is a plastic barrier, and the medial coil element has a plastic barrier, okay? What about tattoo eyeliner and medication patches? Again, if you can remove it safely, do that. So for the 20 minutes of the scan, 30 minutes of the scan, remove the medication patch. There are skin burns from those because they have the metallic backings. The tattooed eyeliner, skin tattoos, usually they're okay. Sometimes there's a lot of iron and that can cause irritation or burns. Again, patient's always right. If they're complaining of discomfort, heating, then you need to take them out or slow down. Wait for them to cool off, and then you can do a test trial. Ton of patches with metallic backings, and I'm sure there's more. This is not inclusive, just making the point. There's lots. Oh, and the other thing, in our neck of the woods, you watch out for those little acupuncture needles. They're very tiny, and they're little looped metal. That also needs to come out. What about pacemakers? It used to be absolute contraindication. Now it's a relative contraindication. We have a protocol for scanning patients with MR conditional pacers. So this is something that we do under nursing supervision. There is a protocol. So you don't just do it on any scanner. You have designated scanners and personnel that can do this safely. And most of the time these days, we just need the manufacturer to do a check before and after to make sure that the pacemaker is still working properly. So this actually happened in our clinic where usually I say no, but this was a case that was sort of forced upon us because the patient had a new cancer and came from outside. It was delayed diagnosis, sadly, because they assumed that that palpable mass was the AICD in the chest wall. And the patient was also pregnant, so breast imaging was deferred. The clinicians pushed for this MRI attempt, even though I told them it's not going to work if she's got this big box. But they wanted to see if the patient could qualify for our I-SPY neoadjuvant trial. And so lots of consenting, discussion, and finally, okay, we agreed to try it. Here's the localizer. There's the T2. So at this point, I take her off the scanner. I'm like, okay, no way. I'm sorry. Unfortunately, and there's the T1 non-fat set, the surgeon was livid that I didn't give her contrast to try. They said she flew here from another state. Anyway, long story short, we actually put her back on, even though I said, it's not going to work. The physics are the physics, but they didn't believe me. So this is where sometimes, you have to prove it to them. And the patient really, really, really was insisting. So we went ahead and I'll say, I did go ahead and do it. So I did the T1 fat sat, gave contrast. And after contrast, it was basically that black hole over the left breast where the tumor was still there. And I couldn't see any piece of the tumor. So the surgeon was hoping if there was any piece of tumor that could be evaluated with signal intensity, that, it was kind of one of those desperate attempts, I think. Because I get it. We're in a really tough situation with a very sad story. So this was at least useful now for my MR safety lecture to prove to people. And these days, I get these calls and I get these emails almost at least once a week where someone says, we cleared them, we can do the MR conditional protocol for the pacemaker, let's get the breast MRI on, and why won't you let me schedule it? And I use this case as the reason for not. So in terms of breast MRI, that generator box is the problem. Even though it may be conditional for the MR environment, the box creates significant artifact over the chest wall and the ipsilateral breast, and even affects fat suppression of the contralateral breast. So this is where I would say screening ultrasound or contrast mammography. If you really need a vascular imaging technique, then contrast mammo would be useful. And if it's supplemental screening, that's definitely not an emergency, so there are other options. What about tissue expanders? I'll jump to the image because image is worth 1,000 words. There is metal in these things, and these days there's a little magnet in these things. So that's what it looks like, all right? Completely blackout, even worse than the AICD. So large area susceptibility artifact, that is non-diagnostic. So you're not going to put any kind of tissue expander in the MR environment. So the magnetic infusion reports have been reported to dislodge even after a spine MR. So this woman had bilateral breast expanders, did the spine MR, and the ports moved around to the point they couldn't find them anymore, so they had to remove them. By the way, the reason it has the magnet is it's how they find the port to inject saline to expand the tissue. So it's a convenience thing. So when it has a magnetic port, you don't want to put it in the magnet. That's almost by definition. There was a study in the plastic surgery literature of 4 tissue expanders. This was ex vivo in a phantom. They talked about temperature increase, not clinically significant. Well, we kind of knew that. They said the valve functioning was not affected. That's okay, fine, but displacement is possible. So artifacts were really the big problem. Again, not that it's unsafe for the patient, but the artifacts render it impossible to read. And then they did a retrospective review of 23 patients with tissue expanders, no kidding. No migration or heating was noted, but fat sat failure covering 30% of the volume of the breast, and water saturation was a problem. So I don't know why the patients were getting an MRI after mastectomy and tissue expander placement. They didn't talk about the indications. I would not recommend this, even though their conclusion was it was okay. They showed these images saying, oh, look, you can still read them. As radiologists, I would say, no, you can't, because the breast with the expander is completely blacked out, right? This is a follow-up MR in the same patient that comes from this publication with the silicone implant. So wait until they have their silicone implant and the expander is removed, right? Not an emergency. So don't put expanders in the magnet. Okay, this is just for your reference, www.mrisafety.com, that's the list. It's a great resource for looking at specific devices. In our workflow now, the devices are flagged ahead of time, and there's a team that vets them, figures out the conditions, and so the idea is it's not going to stall workflow, that they should not be showing up on day of scan at that appointment with a frantic call to the reading room. Oh my gosh, the patient has this, what should we do? I would have to do research. I wouldn't know off the top of my head, right? So this is something you want to do ahead of time as much as possible. So don't schedule them till you know. This is just an example of susceptibility artifact. It's kind of a big black hole, and that's because there was a retained wire fragment from needle localization. Back in the days when we used wires, sometimes the tip would stay behind. If you're still using these, as you know, on your specimen radiograph, make sure that the surgeon shows you all the parts of the wire, that nothing got left behind. This is my all-time example of ferromagnetic versus non-ferromagnetic metal. Platinum coils, platinum, gold, titanium, not ferromagnetic, very MR friendly, not CT friendly, right? Lots of streak, but very MR friendly. Shrapnel, CT friendly, not MR friendly, because that's ferromagnetic. See the difference? So not all metal is equal. So these are the two extremes, non-ferromagnetic and ferromagnetic. Okay, there's also diamagnetic, but that's a whole physics discussion we're not going to get to. Basically, as radiologists, clinically, we care about ferromagnetic, so iron, things like that cause big black holes. Here is susceptibility artifact. This is what a titanium biopsy clip looks like. So those are friendly. I hate stainless steel clips, by the way, because they make big, like centimeter, 2 centimeter artifact. And if you're trying to look at that 1 centimeter tumor, you can't even tell if it's enhancing on MR because the artifact is too big. Okay, let's just quickly talk about pregnancy. MR itself is safe. We used to say wait till second trimester, not anymore. We think that MR is one of the safer imaging tools to use. Again, presuming you're not letting any metal in the magnet, that is unsafe. But the MR exposure is actually fine. If we need to, then we may give GAD in extreme scenarios for specific cases for pregnant patients, but routinely we don't. So we don't do screening breast MR during pregnancy. And that's because the gadolinium can get into the amniotic fluid and in theory could dissociate, okay? Remember, gadolinium, the ion, is a toxic thing, but gadolinium, the chelate, is very safe. All right. Everything is a risk-benefit whenever you're talking about MRI. So for high-risk screening, I wait till the patient's no longer pregnant. We can scan them when they're lactating, and I showed you an example earlier of what lactation looks like. Once you get used to it, you actually can read through that. You might also consider screening ultrasound or contrast mammo nowadays. What about breastfeeding? Well, most of your gadolinium is going to be gone within 24 hours, and the infant dose is tiny. That's the message. Expected infant dose. This is the baby ingesting what might be excreted in the breast milk. Teeny. And so really, and then they have to absorb it. So really, it's safe. I think it's safe. Same thing for CT contrast, by the way, iodinated contrast. You can thank Dr. Bob Brash, who's now retired, but contrast guy at UCSF, he did these studies. So the facts are expected infant dose is a tiny, tiny fraction of the maternal dose, well below 1% for the contrast agents. We give contrast to neonates, remember? We give contrast to pediatric patients. So it's considered safe when indicated. And it's really a theoretical risk, I guess, of some kind of allergy or whatever. But generally, I let the patients breastfeed. I give them the facts, and then it's a personal decision. If the patient really is concerned, then they can pump and dump for 24 hours. So it's just a theoretical risk of direct toxicity. We have lots of patients who are lactating and getting their screening MRs, and they just feed. And so the good news is this is probably okay. All right? What about brain deposition? That's the most frequently asked question these days. NSF, almost no one talks about anymore because we as a radiology community, we have fixed this pretty much. But just to know, the brain deposition was reported in 2014, so we're almost a decade in now. It's dose dependent. There are no histologic changes that anyone has been able to document, and no neurotoxicity has been reported or documented. We also know gadolinium can be found in the liver, the skin, and the bone. In fact, we learned this with the NSF research. So what I tell patients is right now, we have no known adverse clinical consequence of this. Just like we don't really know about anything else that is being deposited in our bodies. It's just that we looked in this case because we could see changes because MR got to be so sensitive, you could see it in the brain. So we only use GAD when diagnostically necessary. That's true for any contrast agent. And when the clinical benefits outweigh the potential risk, we go forward, right? It's always a risk-benefit discussion. Breast MRI screening or diagnostic, you gotta give GAD. In this day and age, that's the clinical standard. One day, maybe non-contrast options or artificial intelligence and synthetic contrast options may work. But for now, you need to give gadolinium, okay? Exception would be silicone implants. That's a non-con exam. Just quickly about NSF, this was a public health advisory first issued in 2006. Nobody really knew what the cause was, felt to be multifactorial, but bottom line is gadolinium was implicated. And this is seen in sick patients. So that's the point. Sick patients, not your usual breast screening patient. So it's a rare systemic disease. I think everyone's familiar now. Some people can die from this. And so our MR safety committee developed a policy in conjunction with the nephrologist. Thank goodness for this. I love our MR safety committee. They basically said, don't deny imaging that's critical to clinical management. So don't be so afraid of causing NSF if you need the MR with contrast. And just so you know, these days, there are group 2 agents and group 3 agents. And group 1 agents. Group 1 are the old agents. These are those linear agents. The chelate wasn't as stable. We all used to use these. We don't use them anymore. I mean, you can, but I think pretty much no one uses them. Group 2, these are the more stable agents. And those are the ones that we use now. And there's multiple different vendors out there. Group 3, we don't know yet whether there is NSF risk or not, but we probably will never find out because we're very sensitive to this. And if a patient has renal insufficiency or renal failure, we'll be more careful. So just remember, you've got to watch out for sick patients, not your usual outpatient. So the good thing is we use group 2 agents in outpatients regardless of EGFR, so we don't test. If they are a healthy outpatient, we just use the group, and we're using group 2 universally, we just go ahead. So that has really simplified workflow. So we no longer do routine screening and laboratory testing for renal failure. And this is, again, in the outpatient setting because these patients are walking in on their own, okay? This is different in the inpatient setting. Last thing, what about contrast reactions, hives after my last scan? And sometimes it's tricky to figure out what exactly was the scan. What did they get? They may or may not know. So in terms of managing reactions in the MR environment, fortunately, anaphylaxis, very rare. And fortunately, in my 20 years, I actually haven't seen one yet, and I hope never to see one. Hives, we have seen. So hives, urticaria, those types of reactions are common, or even adverse event or feeling, like the patient's like, oh, I don't like that taste. That's actually not really a contrast reaction, but they just don't like how they feel after. So nausea, vomiting, headache, paresthesias, these are physiologic reactions, but if a patient gets it, they get it. So when they've had a prior incident or reaction, then they are at increased risk the next time around. If it's moderate or severe, then we may consider trying a different gadolinium agent. We may pre-medicate. And we'll do these during the normal business hours, right? These aren't the patients that you scan after hours when there's less support around. If they have had a prior reaction to iodinated contrast, that increases their risk, not because of cross-reactivity. They're just an allergic person, okay? So our pre-medication protocol is in your syllabus, also available on the website. It's basically a steroid and an antihistamine, and this is all just oral. So there are no IVs or anything complicated. They just take some pills. For mild reaction, again, this is where I'm really grateful for our committee that has made this our policy. You all can adopt this as well if you like. We do not pre-medicate if it's a mild reaction. So if they had hives, I don't pre-medicate. We have them come, and again, during normal business hours, and if they feel like they're getting hives, they can get Benadryl or an antihistamine after the scan, okay? If they really want to pre-medicate, that's fine. Then they can take an antihistamine 1 hour prior to the imaging study, and that basically would suppress the hives, right? So take-home points. No more MR compatibility. Try to wipe that from your language. If someone says MR compatible, I'm thinking conditional now. So there's MR safe, there's MR conditional. That's the one it works in certain scenarios. And MR unsafe should never go into the scanner. So in terms of pregnancy, MRI is okay. Try to avoid gadolinium unless you really need it. And then that's a shared decision-making discussion. You can do screening ultrasound or contrast. Fine to breastfeed, I think, after any kind of contrast. Oh, exception, nuclear medicine studies, not fine, right? Because that's radioactivity. That's a different kind of contrast. But you all know that. But we have to make sure it's clear to the patient. So this is iodinated contrast, gadolinium contrast. And then severe GAD reactions are rare. NSF risk is very low. Yay for our community. We took care of this. If you're using a group 2 agent, you can just do outpatient screening MR without testing. So that's what we do. And then in terms of devices, this is usually the source that we go to, or talk to the manufacturers directly if you know what it is. And if in doubt, don't put it in the scanner. Most of the breast stuff, not emergent. Better to be safe. Thank you so much. It's really been a pleasure to be here with you all, and thank you for staying with me.